Madam Chair and members of the committee, my name is Mona Reimers, and I am a practice administrator of a 26-physician orthopedic practice in Fort Wayne, Indiana. Our practice has 12 locations, which serves patients in 30 counties from 3 states. Medicare regulations significantly impact physician practices, and as the president of the Indiana Medical Group Management Association, I wanted to express my concerns on behalf of my national association. Thank you for having me here today. I echo the concerns of my fellow panel members regarding the flawed sustainable growth rate formula. Stopping the 10.6% physician payment cut scheduled to occur on July 1st should be a congressional priority. Our physicians are committed to our Medicare patients. We currently accept new Medicare patients. However, we are considering significantly trimming back our acceptance of Medicare Advantage patients. If the 10.6% cut were to take effect, we would be forced to consider another operational change, such as reducing the number of traditional Medicare patients we accept. Some of the practices in Indiana are already managing the demand of Medicare patients in their offices by keeping only a few appointments per day available to Medicare patients. Therefore, these double-digit cuts clearly threaten high-quality care to Medicare beneficiaries. My local experience is reflected in recent MGMA national research, where more than 1,100 group practices representing nearly 29,000 physicians responded. As a result of the 6-month financial uncertainty, nearly 24% of practices have begun limiting new Medicare patients, and nearly 50% indicated that an additional 10.6% cut will force them to stop accepting and/or limiting the number of Medicare beneficiaries their practices treat. MGMA research also showed that more than half of responding practices are reducing administrative and clinical staff. 2/3 described how information technology and clinical equipment investments are also sacrificed or postponed indefinitely. However, Medicare's challenges are not solely caused by the annual SGR struggle. For the past 2.5 years, we've encountered continued and growing frustration associated with the Medicare Advantage program. In 2005, Medicare Advantage was 3.6% of my practice's Medicare charges and has grown to 24% in 2007. Our Medicare Advantage patients share our practice's frustrations. They don't know the rules. Practices like mine are bogged down trying to help patients understand their plans and navigate the many administrative complexities. My practice has been forced to hire 2 full-time staff just to deal with the avalanche of beneficiary questions and additional paperwork associated with Medicare Advantage, and even that is not enough. MGMA has fielded countless practice inquiries and concerns regarding Medicare Advantage and has therefore developed 4 simple requests that, if enacted, would greatly improve the operational aspects associated with Medicare Advantage, as well as improve provider and patient understanding about the program. In recent MGMA research, over 56% of respondents said they could not accurately identify Medicare Advantage patients, with 90% of respondents indicating that patient insurance cards provided ineffective identification. Because patients do not know what coverage they have, I have had to direct my staff to contact Medicare or the Medicare Advantage plan each time the Medicare patient walks through the door. This administrative burden could be avoided with the standardization of Medicare Advantage ID cards. If standardized cards were issued, we could quickly identify the type of Medicare Advantage plan the patient is enrolled in, and we could then know precisely where to bill the claim and what contact information to use for further follow-up. These ID cards should be required to contain a toll-free number meant for providers to be able to get answers to questions and quickly check eligibility and/or claim status, just like traditional Medicare. Our second request is the elimination of deeming in Medicare Advantage. Doing so would allow practices a fair opportunity to review, negotiate, and understand contracts with plans. Deeming allows a Medicare Advantage plan to consider a physician as accepting their contract if the patient presents a Medicare Advantage card prior to service. Often, we are essentially forced to sign the last page of a contract without knowing what the rest of the lengthy and non-negotiable contract says. For example, every day we treat arthritic patients who are driven to their appointments by family members that took time off work. They present one of 100 non-standardized identification cards upon arrival at the front desk. At that moment, we must decide whether we will treat this patient. It is cruel to delay or deny treatment because it's just impractical to review a contract while a patient is waiting services. Yet being denied the opportunity to review and negotiate the terms and conditions prior to rendering services is completely contrary to fair contracting principles. Our third request is the elimination of all products clauses in plan contracts. Most states already outlaw these clauses. In order to protect physician practices from accepting all patients in all variations of insurance products offered by a given insurer. For any contract to be binding, there must be a quid pro quo, meaning both parties have received something from the other, but this does not exist for Medicare Advantage plans and the physician if contracting by default occurs. Some states, like Indiana, have addressed this practice, but Medicare Advantage plans are exempt from these state laws. We urge Congress to prohibit the use of all products clauses in the Medicare Advantage program. Our final recommendation is that Congress apply and enforce the same timely payment provisions of Medicare Advantage that exist for traditional Medicare. Traditional Medicare does a great job paying promptly and accurately, but my office's accounts receivable from Medicare patients is 50% higher than it was in 2005. This is primarily due to Medicare Advantage. We currently spend triple the workforce to collect what's due from Medicare Advantage payers than what we use to collect from traditional Medicare. In following up on unpaid claims with traditional insurance payers, we have the avenues available to us, such as the Department of Insurance and federal agencies for ERISA plans. With Medicare Advantage, there is no comparable resource. Our Region 5 office from CMS has heard plenty from plenty of us and have offered some help, but it has been ineffective in causing any root change to the behavior of the payers. Applying the traditional Medicare prompt payment law to Medicare Advantage plans would be both logical and fair. Addressing our recommendations would greatly improve the medical community's perception of and willingness to participate with Medicare Advantage plans, therefore strengthening the program overall for beneficiaries as well. Thank you for this opportunity, and I'm happy to address your questions if you have any.